All right, everyone, we'll go ahead and get started over chapter 34. This is over obstetrics and neonatal care. Obstetrics is, of course, relating to pregnancy and all things related to pregnancy. And then neonatal care is referring to a newborn, right? First part of life. And so we'll talk about some of the more complicated parts of pregnancy um, and how we deliver babies and the complications that we can encounter when delivering a baby. So make no mistake, EMTs do deliver babies. And so that's something I've done a couple times. And so, with that said as well, um, we've been delivering babies since the beginning of time without doctors and EMTs intervening. So, birth is a fairly natural process. We're usually there just to facilitate it. Don't get me wrong, things can and do go wrong where we have to intervene. And we'll talk about how we intervene for those. But, it's a pretty natural process of delivering a baby. It's been happening, again, since the very beginning of time. And so, or beginning of human life. And so just be aware of that. That a lot of times we're just there facilitating. So overwhelmingly, the vast majority of deliveries will happen in the ER. A general rule to know is that um, when you've had multiple babies, right? When a woman has had multiple babies, the chances of them delivering outside of the hospital would increase theoretically because the structures have been loosened. And so a general rule is like the first baby, from the time of onset of labor to the time you're delivering is hours and hours, sometimes days. Okay, so it's a lot of hours, like more than 8 hours. Okay, for like a new mom. Now, someone that's had 2, 3, 4, 5, 6, 7, 8 kids, it's going to get quicker and quicker. Okay, and it's just because the structures are looser. They just are, and the body's been adapted for birth. And so, when you have a patient, you get a call. Oh, it's a new mom. They just had their membrane just ruptured, right? And so you have time. It's usually not an emergency. But if they're like, oh, this is her 8th child and her membranes have ruptured 5 minutes ago, they might be delivering in the next few minutes. And so what I'm saying is the more babies you have, the quicker you're going to deliver, is a general rule. And so you must decide whether to assist the delivery on scene or transport to the hospital. So they say, stay and play or load and go. Usually my general rule of thumb is if delivery is imminent, like there's crowning or, like I said, it's their 10th child, then yeah, you're going to have to stay on scene and deliver that baby right then. You really don't want to do this in the back of an ambulance if you can avoid it. You'd rather do this in their house or somewhere like that. It's going to make a mess. Back of an ambulance, the stretcher is right up against the wall or the door of the ambulance, so there's not a lot of room at the foot to do this. It's better. You don't want to do this in an ambulance if you can avoid it. And so let's talk about some quick pathology review, physiology, anatomy. So the ovary glands are the equivalents of testicles of the male. There's one on each side. They're laying in the abdomen. Men, they're sitting right about where your bladder would be. So if your bladder's ever felt really full, the uterus and ovary are sitting very closely to that. And so the uterus the ovaries contain thousands of follicles, and each of these follicles, little cells, will contain an egg. And so within the egg, that's what a woman is ovulating every 28-ish days. We've talked about this. Is one of those thousands of follicles. So when a lady is born, they're born with all their eggs. Okay, it's different from men. Men reproduce sex cells throughout life, but women, what you're born with is what you're born with, and so they just mature as we age, and then they'll eventually mature so much they'll rupture and release an egg. And so that should happen once every 28 days. Now, with that, can you release multiple eggs at once? Yes, you can. That's how you get multiple gestation pregnancies. Okay. And so, or one of the many reasons you can. And so the fallopian tubes, we've talked about this, so I'm going to zoom through some of this. This is the ovary, this is the fallopian tube. So there's these fimbriae that will come down and grab this egg. So this little bitty egg will come out of there and it'll travel through the fallopian tube, and hopefully, if you're looking to get pregnant somewhere in this fallopian tube, sperm will swim up and impregnate or fertilize that egg. And so usually that'll happen in the fallopian tubes. And so the fallopian tubes are carrying the egg from the ovary into the uterus. So it looks like this, from here into there. And so generally implantation will happen somewhere up here near the isthmus of the uterus, or the isthmus of the uterus. And so the idea is that if it implants here, then you should then it'll get bigger and bigger. Okay, so that's the idea. So I'll just explain that. So the uterus is a smooth muscle. You must know that, and this is what causes contractions during labor. This smooth muscle will contract. It is not skeletal muscle. It is not cardiac muscle. It is smooth muscle. Very important to know. So, and this will help push the fetus out of the uterus through the vaginal canal, the birth canal, right? And so this is what it is. And so the birth canal is made up of the vagina and the lower third of the uterus called the cervix. Okay, so this is technically called the birth canal. And so something to point out is this is the bladder, okay? And so this is their back. The lady's facing this way, okay? Her eyes are looking this way. And so the uterus, okay, this is a vagina, right? And so normally the uterus sits like this. And so it's kind of sitting on top of the bladder. And so if you ever heard women like having problems needing to go to the restroom a lot, well, yeah, there's like a 12-pound weight sitting on top of their bladder that's compressing it throughout pregnancy. So this is kind of one thing to keep in mind. The bladder gets relatively compressed, so it's a lot smaller in size. One, two. Another thing I'd like to point out is the what we call the fundus of the uterus. So this is the highest point of the uterus, and so if this is the belly button, the height of this should be about at 20 weeks. It should be about the height of the belly button. Okay, and then up here it'll obviously grow upwards, and then so this is what we call vertex presentation, where the baby's head is facing down towards the vagina, and this is ideal. This is how you want to deliver a baby. Now, what's this thing? This is called the placenta, and so the placenta is this I'll show you a picture of a real placenta. But it's basically this tissue that is the connection between mom's uterus and the baby. And so this is where all the nutrients and material from mom are passed through the placenta into the umbilical cord into the baby. And so that's how this works. Okay, and so we'll talk about all these a little bit more. And so let me talk a little more. The amniotic fluid is this fluid. This is the baby's urine that is inside this sac, right? That is surrounding the baby to cushion it. Okay. The baby's constantly peeing and swallowing their pee, the amniotic fluid, and creating more and more. And so, you want amniotic fluid, not too much, not too little in pregnancy. Okay. Now, the vagina. Let me start with this. We're in healthcare, so again, realize that this is a privilege to take care of every patient we take care of, especially in the case of like obstetric trauma or delivering a baby, right? So yes, there is a vagina on the screen. We have to use the word vagina. And so this is medicine, so just be prepared for that. You will see genitalia on the ambulance, okay? It just happens. And so just be aware, you need to be prepared for that and be mature for that. This is a privilege to take care of these patients. There has been decades of trust that have built up to allow you, a brand new EMT or an EMT student, to look at a lady's vagina in the back of the ambulance or to deliver a baby. And so don't violate that trust or do something silly or say something inappropriate, okay? So the vagina is the outermost cavity of the female reproductive system and forms the lower part of the birth canal. It completes the passageway from the uterus to the outside world. And so basically the skin, what you should know is the perineum is the skin between the vagina and the anus, okay? And so this would be perineum and this would be perineum, okay? And so the reason this becomes kind of important is sometimes during pregnancy, this can, the vagina is very large, trying to push out a baby, so this can tear. And so sometimes instead of letting it tear, doctors will just cut it surgically, and we call that an episiotomy. And so it goes like this. And so it's an episiotomy, and you just kind of, not us, but a doctor will cut this. And so the breast produce milk. That's really the idea of breasts, is they produce milk, lactation, and it comes out of the nipple and it would be delivered to the baby for the nutrients. Okay, there's a lot of breastfeeding is scientifically proven to be very helpful for babies. It is far superior to formula. And so there's a lot of antibodies that are passed to the babies and nutrients and bonding with the mother. So breastfeeding is good, but not everybody can do it. It's not for everyone. Okay. Now, early signs of pregnancy are going to be breast tenderness. It's because of the surge of estrogen and progesterone. One, two, you just be aware of sometimes patients will say, "Oh, I have a high amount of vomiting." Okay, and so you might see a lot of vomiting in early pregnancy. So pretty much anyone of childbearing age with unexplained vomiting, you're probably going to run a pregnancy test in the ER or the hospital to make sure they're not accidentally pregnant or pregnant and didn't know it. Okay, and so this is the placenta. Okay, and so the placenta is here, and so basically this is what attaches to the uterine wall, like the other side where his fingers are, is what actually attached to the uterine wall, and all these come together, these small vessels, to form the umbilical cord. And so typically you want the placenta, somewhere up here, okay? Like you want the placenta somewhere, whoops, up here. You don't want it down here, and I'll explain why in a bit. But basically, that's the idea of the placenta, okay? And so this is what is connecting baby to mom. But everything that's given between baby and mom has to travel through the placenta. And so this is why certain medicines can and cannot be transferred to the baby. And so it's complicated. And so if you ever wonder like why that is, it's because of the placenta. Okay. And so after delivery, the placenta, which has been supplying the baby, will separate from the uterine wall and it'll deliver. And so this is a delivered placenta. So after you deliver, the mom delivers the baby, you want the placenta to come out. And then so that placenta is sent to a lab to make sure that all of it came out, because some of it, if like a piece of the placenta is retained in the uterus, it can cause infection. And so the umbilical cord is interesting. So to remember what an umbilical cord is, you can remember the mnemonic AVA, AVA. And so that's just telling you that you have two arteries and one vein. But you're going to look at this and be like, what? Huh? The arteries are blue? And they look like, so yes, the arteries in this case are sending oxygenated blood, or I'm sorry, deoxygenated blood to the heart. So this only happens 2 times that we know of in this class where we have deoxygenated blood in an artery. So that would be the pulmonic artery, right? And so also where we have deoxygenated blood, and then also the umbilical the umbilical arteries. Okay, those are the 2 examples. Now the umbilical vein has oxygenated blood in it, and you can see it's collapsed on itself like normal veins are. Okay, and so that is what a normal umbilical cord looks like through a cross section. So when you deliver a baby and cut it, you really should look, and you can see this with your naked eye. You should see 3 holes, right, within the wart and jelly. You should see 3 holes, and the mnemonic is artery, vein, artery, and it should be in that order. The vein should be in the middle. Okay, because sometimes you only have 1 artery, 1 vein, and then the baby's usually going to be small birth weight, stuff like that. So the fetus develops in this bag-like membrane called the amniotic sac, and inside that amniotic sac is amniotic fluid. How much fluid? Anywhere between like half of this bottle and the full bottle, so anywhere between 500 to 1,000 milliliters. And so the idea is to help cushion and protect the fetus and to allow it to grow. So obviously, you can imagine like that little squishiness that would give the baby to protect them from accidental trauma and to allow them to stay warm. And there's a few other benefits, right? And so the fluid is released in a gush-like fashion, right? When the sac ruptures, we call that, oh, my water broke, right? That would be the gush, right? So the large amount of water that's coming out is the baby's urine, amniotic fluid, okay? And so many normal changes occur in the body that are not all directed to the reproductive system. So you'll have changes, and we'll talk about this, in the heart and the muscles and the respiratory system. So the hormone levels certainly increase. So this is why some pregnant women can have like severe mood and psychological disturbances. It's because of, well, one of the reasons is because of hormones, right? And so you have to have a high level of progesterone to support pregnancy. You'll end up with an increase in prolactin eventually, and oxytocin, and HPL and relaxin and all these other hormones that are produced to support pregnancy. So obviously any change in the hormones of any human, male or female, is going to change their mood usually. And so be aware of that. And so also, the uterus is displaced from its protected position within the pelvis. Normally, the uterus is tucked in like next to your bladder. And so when you have a baby, it's growing out into your stomach, right, into your abdomen. And so it's more exposed to trauma, okay? So the rapid uterine growth usually occurs during the 2nd trimester. So we divide pregnancy into trimesters. So tri meaning 3, so 1, 2, 3, okay? And so it's in the 2nd trimester is where you'll see this most rapid growth. And the first one is just a bag of cells, mostly. And then eventually it'll kind of turn into a baby, and then eventually it's like it gets into a pretty big baby, okay? And so if you were to draw this in a chart, right, like if this is growth over time, so it's going to be like pretty small, and then it shoots up, and then it kind of levels out. So we divide this like 1st trimester, 2nd trimester, 3rd trimester, okay? And so the respiratory capacity changes with increased respiratory rates and decreased minute volumes. So instead of breathing 12 times a minute, they may breathe 20 times a minute, but they're also going to have a decreased minute volume. Okay, so the minute volume, remember, is tidal volume, as in how much air we're taking in a minute, times respiratory rate. Normally that's around 5,000 to 6,000 milliliters, or 5 to 6 liters a minute. So blood flow gradually increases to allow for this baby to grow, but also for the perfusion of the uterus. So the uterus has a rich blood supply to it. Okay, big arteries going to the uterus, and so we increase blood supply for that to supply the uterus its nutrients to grow. It is a muscle after all, and also for the blood loss expected during childbirth. You're going to lose blood during childbirth for sure. How much? Anywhere between like 1 to 500 milliliters would be normal. Normal, I would say more than 500 is not normal. And so normal of red blood cells increases, the plasma increases. If you've ever seen a pregnant lady, they tend to have a glowing type look to them. It's because they're increased plasma. And so remember, plasma is the yellowish stuff of our blood, like the clear liquid stuff. And so the speed of clotting increases. The patient's heart rate will increase up to 20%. I would know this number. I don't know why. I've seen this tested. Okay, whoops. The GI system changes, so you can have what's called gastroesophageal reflux, also known as GERD. This is also known as heartburn, where the esophagus, the sphincter down here becomes weak, and so you can shoot stomach acid into your esophagus. Okay, we call that heartburn. Nausea is very common in pregnancy. In fact, it can be life-threatening. It can be so bad. We call that hyperemesis gravidum. And so what happens is, when you take a pregnancy test, we're testing for HCG, right? It's a pregnancy, human chorionic gonadotropin, the B subtype specifically. And so when that increases at high levels, the brain can think like, oh, this is this is toxic. This is like not a good thing in our blood, so we should vomit. And so it tricks the brain to thinking it's toxic, and so you vomit. And so this is why people get like morning after. This is why people get sick with pregnancy. One of the reasons. Okay. And so weight gain during pregnancy. So you will gain weight. You should gain weight during pregnancy. Okay. And so that's going to have an effect on the heart and the impact the musculoskeletal system, especially the joints. It's like the knees. Think about if you're carrying around a 30-pound backpack for the next 9 months or 3 months or however long, you're going to feel it. Okay. And so the joints become looser or less stable. So there is a hormone called relaxin. You don't need to know the name, but this allows the joints to relax to facilitate delivery, specifically the pubic symphysis. Remember the pubic symphysis, where the pelvis joins is a joint, and so the idea is if the patient produces relaxin, that will relax to facilitate delivery. And so changing the body's center of gravity changes. Obviously, they're carrying again a 30-pound backpack or stomach pack, or a fanny pack, and so keep that in mind. Most pregnant women are healthy. Again, this has been happening since the beginning of time. Some may be ill when they conceive or become ill during pregnancy. Use oxygen to treat any heart or lung disease in a pregnant patient, sure. And so you can get something called gestational diabetes, okay? And so gestational diabetes will develop during pregnancy in many women who have not had it previously. And so the body produces a hormone, you don't need to know the name, but it's called HPL. And so what happens is the body will create this resistance to insulin in order for like mom cells, like her muscle cells and cells, to not take all the glucose and not share it with baby. So what happens is this HPL tells mom cells, well, don't take all the glucose, so it can be passed on to baby, so baby can grow. And sometimes this is too high, and when it becomes too high, you can get what's called gestational diabetes. Well, the good thing is you can treat this pretty easily with diet and sometimes medication. And the other good thing is as soon as you deliver, this will go away. This will end. So this usually doesn't stay after pregnancy. Now, hypertensive disorders are unbelievably high yield, so pay attention, take notes. Gestational diabetes is the presence of high blood pressure in the absence of other systemic effects. So how do we define hypertension generally in the United States? It's really when it's above 140 over 90, but it would be more severe when it's 160 over or a diastolic over 110. And so those will make sense, right? Like those are intuitive numbers. Okay, it's obviously going to be more severe the higher the number is, and the number happens to be 160 over 110. And so preeclampsia is where you start. So this is very important. Pay attention. This can develop after the 20th week of gestation. So you're entering your second trimester. You're in your second trimester, and so what happens is preeclampsia is hypertension, headache, visual abnormality, swelling of the hands and feet, anxiety, right? And so how this happens, this is complicated, but just stick with me. This is the uterus, okay? And here's baby sitting in its amniotic sac, okay? And remember, baby's connected to mom and getting all its nutrients through its cord through the placenta. Well, what happens in preeclampsia and eclampsia is this connection becomes compromised for whatever reason. It becomes compromised. And so the way that mom's body fixes this is it tells the vessels, oh, well, let's just squeeze down tighter so we can really push fluid down to baby. Okay. And so you end up with hypertension. And when you get this hypertension, it causes issues with the liver and the kidneys and the rest of the body, the eyes, everything for mom. And so what can happen is the blood pressure can get so high, and your electrolytes and your proteins can get so far out of whack, you can end up with something called eclampsia. And so as a general rule is any time that a pregnant patient has a seizure during pregnancy, especially after the 20th week of pregnancy, with hypertension, we call that eclampsia. Okay? So to clarify, preeclampsia is high blood pressure, really high blood pressure and some protein issues and electrolyte issues, liver issues, kidney issues after the 20th week of pregnancy. Okay, so preeclampsia means, okay, high blood pressure in pregnancy, basically. Now, eclampsia is a true life-threatening emergency because mom will have a seizure. Remember seizures where they're shaking, right? These are generalized seizures as a result of this hypertension. And so this is a true life-threatening emergency. Why is that? Is mom breathing very well during the seizure? No. Is she using up a lot of oxygen? Yes. Is the baby being well perfused? No. The baby's already not being well perfused because the mom had preeclampsia. So this can kill the baby. It can kill the mom. And so this is a very, very, very important life-threatening emergency. So remember, one phrase, eclampsia equals seizures with hypertension in pregnancy. Eclampsia means seizures with hypertension in pregnancy. Now, preeclampsia means no seizure, but you have hypertension in pregnancy. Okay? And so how you treat this is you put the patient in the recovery position on their left side, right? Left lateral recumbent would be the other word for that. Maintain her airway, give oxygen. If vomiting, you're going to suction the airway. To vomit during seizure is fairly common, so be prepared to protect the airway and be cognizant of the aspiration. And you're going to rapidly transport and call for ALS. Why do you call for ALS? There's a medicine that we carry on ambulances. There's two, but really one that we can give pregnant ladies to have them stop seizing and save their life. Okay, so this is a very, very, very important thing to know about eclampsia. And this does happen. And so transporting the patient on our left side can also prevent supine hypotensive syndrome. So we've covered this before, but this is a patient. And remember, this is the heart. Whoops, this is the heart. And the aorta comes out of the heart like this, and it has all these branches, right? And so it eventually goes down into the pelvis, right? So that's the aorta. And this is the patient's right. But also, remember, all of it comes back up on the patient's right side in the big vein that we call the vena cava. Well, if the patient is laying on their right side, the weight of the baby, because this vena cava sits not in the center, if this is the spinal cord, it does not sit directly on top of the spinal cord. It sits to the right of the spinal cord. And so the idea is you put the patient on the left side so the weight of the baby is not pushing on the, the vena cava. And so when it does push on the vena cava, so like if a pregnant lady lays on their back, I've seen this actually during OB rotations, right? To where we do like a sonogram, and they'll have supine hypotensive syndrome. They'll get dizzy, start sweating, short of breath, anxious. And it's because the baby's weight is pushing on this big vein. And so it's causing a form of obstructive shock. And so they get shocky and they don't feel good. And so and they can even have syncope and pass out. And so just be aware of that. The position that you lay a pregnant lady is always on their left side. Okay? And so we'll talk about bleeding in pregnancy. There's a few different ways this can happen. The most common way that we've talked about in gynecology, but here it is being talked about again, so that means it's important, is an ectopic pregnancy. Remember, the word ectopic means it's out of place. So we have a pregnancy out of place. Remember, a baby should implant in the uterus over here. But what happens in an ectopic pregnancy is the egg came fertilized in the fallopian tube, which is normal. So sperm traveled up here and fertilized this egg, and the baby implanted in the fallopian tube instead of traveling its way down into the uterus and implanting. So what happens is this fallopian tube is just a tube. And so as the baby grows in size, it's going to cause tearing and stretching, and eventually this can rupture. And if it ruptures, it's a life-threatening medical emergency, and it could very well kill mom and the baby. And so how this presents is bleeding in the first trimester of pregnancy. So you'll be like, lady hasn't had a period in 7 weeks, and now she has vaginal spotting. with lower right or left quadrant abdominal pain. What do you suspect? Is probably an ectopic pregnancy, okay? And so this is what I'm showing you here. I've showed you this picture before. This is the uterus. You're looking down, like from the belly button, looking down at their feet. So this is the uterus, okay? And so this is a normal ovary right here, and this is the fallopian tube. But what happened over here is underneath this area is the uterus, or is the ovary. The baby's growing inside this little bitty tube. See this tube right here? That's how big it's supposed to be. This is how big it is because a baby's growing in it. So this is called an ectopic pregnancy, okay? And so where this most commonly happens is in the ampulla, which would be right here. But this is a life-threatening emergency if this ruptures. You have to go to surgery to fix this, or else the patient will die. If you don't have surgery to fix this, you will die when they get this big. If you catch it early, you can have an abortion. It's an abortion. You give the patient a medication to have them abort that baby, unfortunately. But if you don't, they will both die. Okay, so now consider an ectopic pregnancy in the presence of severe abdominal pain or vaginal bleeding during the first trimester. Okay, so if they're like, oh, a patient's 8 weeks, hasn't had a period, and now they have vaginal bleeding, yeah, it's probably an ectopic pregnancy. Consider the possibility in a woman who has missed a menstrual cycle and now complains of sudden severe pain in the lower abdomen. Again, this is why we ask, when is the first day of your last menstrual cycle? They should be every 28 days apart, give or take. But you can ask the history, right? Oh, do you normally have your period every 28 days? Oh, it's every 30 days for me. Okay, well, it's been 60 days since you had a period, so you're probably pregnant. Okay? And so hemorrhage from the vagina that occurs before labor begins may be very serious. We're going to talk about what these are. It may be a sign of what we call spontaneous abortion. Remember, when we think of like abortion, like what we hear in the news, that's called an elective abortion. So you're electing to terminate that pregnancy and abort it. But the word abortion in medicine actually just means miscarriage. Okay, so spontaneous abortion is a miscarriage, meaning the baby was spontaneously aborted because the body rejected it for whatever reason. Okay, it can be a lot of reasons why. It's usually no one's fault. Well, I mean, no one's intentional fault. And so, an abruptio placenta, we're going to talk about what these are, but the placenta separates prematurely from the wall of the uterus. Okay, and I'll show you a picture of this coming up. Now, placenta previa, the placenta develops over and covers the cervix. And so let's talk about this. This is placenta abruptia. Okay, so when I see the word placenta, it sounds like, oh, the placenta. That's easy. But it's abruptly separating, okay? And so what happens in a placenta abruptio is the placenta is normally hugging the wall of the uterus, but it will tear off of the wall, and that's painful, one, okay? And so if you have painful vaginal bleeding and pregnancy, that is called placenta abruptio. Okay, so that is a life-threatening medical emergency. You can die of this. The baby will likely die too, because think about it. This is the baby's blood supply in the placenta, and you are abruptly rupturing some of this off of the wall of the uterus. So the baby's not going to get their full amount of nutrition now, their blood, their nutrients. So this can kill the baby. So how does this present? This is in late pregnancy, and the patient will present with painful vaginal bleeding, placenta abruptio, okay? Abruptio placenta, whatever you want to pick. Painful, this hurts, it's abrupt, okay? So you can think like, oh, your girlfriend or boyfriend breaks up with you abruptly, that hurts, right? That's going to be painful, okay? So that's one way to think of this. This is placenta abruptio, it's painful vaginal bleeding in late-term pregnancy, okay? Very life-threatening for the baby when this happens, and mom, okay? It's very painful. Now, whoops. Placentia previa literally means you can preview the placenta. So normally you want the placenta to implant anywhere but over the cervix, okay? And so it's okay if the placenta implants here or even here, but it's not okay when it implants here. Because remember, this is the cervix. If you were to look in a vagina, right, and there's going to be a little hole right here, that's the cervical os, the cervical opening. So what happens is you can see the cervix over the cervical os. And so what happens is placenta previa is you can literally preview the placenta. So not that we do this, but if you were a doctor and you were to do a speculum exam and look in the vagina, you would see the placenta. You can preview it. And this is painless bleeding. Why is that? Why does this happen? Well, the placenta can migrate throughout pregnancy, and so sometimes it'll get stuck down here over the cervical os late in pregnancy. And so when they're getting close to deliver, the cervix will dilate, and when it does, it'll cause blood to escape out of this opening through the vagina. And so this is painless vaginal bleeding late in pregnancy, because you can literally see the placenta. If you We don't do this, but if you were to stick a speculum and look inside the vagina, you're going to see the placenta. That is called placenta previa. Okay, both of these are life threatening. Both of these present with vaginal bleeding. This one is painful. This one is painless. Both of them are equally problematic because the mom's bleeding and the baby's not getting their full nutrition. Okay. So an abortion is passage of the fetus and placenta before 20 weeks. It can be spontaneous or induced. We can do this with medicine, right? So I won't tell you what they are, but there's medicines you can give to basically demise the pregnancy and end the pregnancy. So that's one medicine we give, and then the other medicine you would give is to relax the cervix, and then you could give another one also to squeeze down on the uterus, and so it'll expel the dead baby. So that's a hot topic, talking about abortion, but just note that that's the science of it. Okay. And so most serious complications are bleeding and infection. So if like, say someone does like a backroom abortion, right? And so they don't have a proper abortion, you have to worry about like infection. You also have to worry about like not all contents of the baby and the placenta and the amniotic stuff being expelled. If that's retained in the uterus, it will become infected. And so you can get, again, you can get septic and very sick from this. And so just be aware. You can also lose a lot of blood from this. So, someone sticks a coat hanger in the cervix and starts moving it around, they're going to cause damage, and so you could end up with severe bleeding. You can end up with like all sorts of problems by doing these types of abortions. Okay. Now, with that, also abuse can be a thing. So there could be like traumatic, like someone punching a pregnant lady in the stomach or in the abdomen, trying to induce trauma to induce abortion. That unfortunately can happen. And so pregnant women have an increased chance of being victims of domestic violence and abuse. And so abuse increases the risk of abortion, unfortunately, premature delivery, and a low birth weight. The woman is at risk from bleeding, infection, and uterine rupture. So again, if you're late in pregnancy, the uterus is out of its protective shell of the pelvis, and now it's out here in your big old belly. If you were to get kicked in that or traumatically blown to that or something like that, you could actually rupture the uterus. Because think about it, the uterus is normally the size of a fist, and during pregnancy, it's the size of a friggin' baby. It's huge. And so when it gets really big like that, it thins out. And so sometimes it can become so thin, it can rupture. Okay. So pay attention to the environment for any signs of abuse. Talk to the patient in a private area, away from the potential abuser if possible. Okay. Now, substance abuse is fairly common in the United States. The most common way this happens is through alcohol, and we call this fetal alcohol syndrome. And so it's basically an infant who the mom was drinking their alcohol or abusing alcohol during pregnancy. So this is an important reason why women should not drink alcohol during pregnancy, not even just a little bit. And so, interestingly, this presents with a very hallmark pattern called a smooth philtrum. And so that's this. So normally on the top part of the lip between the nose and the upper lip, there is a divot right here. And in fetal alcohol syndrome, that will be absent. And so this is smooth. And you've probably seen someone with this. And they also have a thin upper lip. Okay? They're usually also intellectually they have intellectual disability. Okay? So obviously this can kill the baby too, as well. But if they deliver it, usually they'll have some type of, like, this is a real baby, right? Unfortunately, or a real child. And so you can see this doesn't have that divot that should normally be there. And they have a thin upper lip. Usually they have wide-spaced eyes as well. Small nasal bridge. There's a lot, like this is explaining all of it, but just know that happens. So the most common substance abuse in pregnancy would be alcohol. And so in Texas, in fact, we drug test all mothers when they deliver in a hospital for that reason. If you test positive for methamphetamine while delivering your baby, it is no longer your baby; it's the state's baby until they can determine it's safe to go back to you. And so, special considerations for trauma and pregnancy. With a trauma call involving a pregnant lady, Uh, you may have two patients, right? You have the woman, the patient, and her unborn fetus. Okay, and so trauma to a pregnant lady may have a direct effect on the fetus. Keep that in mind, especially abdominal trauma like blunt trauma, car wrecks, stuff like that. Seatbelts go right across the baby. And so pregnant women also have a risk of falling. We talked about that. Their center of gravity is different. They also have looser joints. So their knees and their ankles aren't as tight as they normally are. So they can't pivot and move as quick. Okay. Pregnant women also have an increased rate of overall total blood volume with a 20% increase in heart rate. That's the second time they've said that, so it's probably important. Okay. May experience a significant amount of blood loss before you see a sign of shock. Okay, remember they have this increased blood and they can lose a lot of blood, but they also are using that blood to protect the baby, so and provide for the baby. So still minimizing blood loss is the goal. Okay, and so with that said, that's what I'm saying. The fetus may be in trouble before the mom is, as far as like perfusion. And so when a pregnant woman is involved in an NVC, severe hemorrhage may occur from injuries to the uterus. Remember, the uterus is a smooth muscle. It is normally protected by the pelvis, but when you're pregnant, it is out in the belly. And so it is very, especially late term pregnancy, the uterus is very thin because it's stretched out. And so you can rupture that pretty easily or damage it pretty easily with blunt trauma. Okay. And so just be aware of that. Trauma is the leading cause of abruptio placenta. So remember, abruptio placenta, this is when the placenta abruptly will detach from the uterine wall, and this is painful bleeding late in pregnancy. Okay, painful vaginal bleeding late in pregnancy. So they could tell you, oh, mom was kicked in the stomach by a horse, and now she has painful bleeding. One of the many things you would suspect is abruptio placenta. Okay, now you can also get a uterine rupture, which I don't know if they're going to talk about, but this is what it sounds like. The uterus is the smooth muscle that's holding the baby. If that ruptures, the baby is no longer in there, so you will feel baby parts on the stomach. So you would palpate the abdomen and you would feel like, oh, that's a leg, that's an ear, that's a head, right? You can feel it very clearly. That is very bad when that happens. They're probably both going to die. So that it's just really, really bad when that happens. But it can happen. Who's at a high risk of that? Those that have had C-sections. If you had a cesarean section where they went in there and cut your uterus open to remove your baby, that scar tissue is thin. And if you've had multiple C-sections especially, you're at a very high risk of uterine rupture. And that's generally why OB doctors won't let you have more than 4 or 5 C-sections for that reason. So improper positioning of the seatbelt can result in injury to the pregnant lady. Okay, so look at the belly for bruising. Cardiac arrest is the same. The only thing that you would do is notify the hospital that you have a pregnant patient who's in cardiac arrest. Sometimes you can do what's it called? Not us, but doctors will do an emergency cesarean section if the mom's dead. They'll just go in there and slice up in the uterus and take the baby out while doing CPR and try to revive the baby independent of mom. You do that in late pregnancy only. It's rare. And so assessment management, so focus is on the woman, right? Keep in mind, if the mom dies, the baby will die, right? And so, unfortunately, if you got to pick between the mom and the baby, you got to pick the mom, okay? Because the baby will die without mom. So keep that in mind. Be prepared for vomiting and aspiration. Remember, aspiration is when you choke on the vomit, or not choke. Oh yeah, choke on the vomit. Okay. So you can attempt to determine the gestational age to assist you with determining the size of the fetus and the position of the uterus. Okay, and so a general rule is at 20 weeks, the fundus should be at the level of the belly button. And so a good question just to ask these patients, have you had prenatal care, right? So are they seeing an OB doctor? They're getting their sonograms, getting their anatomy scans. They're being followed. Generally, if they say no, then that's a huge red flag. That means that this might be a very complicated pregnancy and delivery because it's been unplanned and no one, But generally, if they're like, oh yeah, I've made all my appointments, everything's going fine, then that's good. Okay, so those are the good patients, But the good patients don't call 911. So it's more common to be like, oh, I didn't know I was pregnant, and now they're having a baby. So no prenatal care. Prenatal care greatly, greatly, greatly reduces mortality around delivery of a baby. And so follow these guidelines when treating a pregnant trauma patient. Maintain an open, just like any patient, maintain an open airway, administer hypofloxacin, ensure adequate ventilation, access circulation, and transport the patient on her left side. What's the other word for this? Left lateral recumbent position. And so be culturally aware. There's some people, this is again a gift to take care of any patient, but especially a vulnerable pregnant patient or any patient dealing with genitalia. And so just be aware, I may not think it's a great idea to have your baby at home, but it's not my opinion. It's not up to me. I'm not their doctor. And so some people want to have their babies at home or at a birthing center or something like that. I personally don't think that's a great idea, but that's their right. And so they do have the right to do that. It's not against the law to make bad decisions like that. And so also be aware that some patients won't let males examine them. And this is like a religious thing. And so remember, even pregnant patients have the right to refuse any aspect of your care, including your exam, or you assisting them delivering or whatever. So just be aware of that. Watch for that on exams. Patients do have the right to refuse care, even if they're pregnant and actively in labor. They have the right to refuse care. So if you have a female patient, they can do it. I'm sorry, female partner. So just be aware of that. On the ambulance, I've never had a problem with that. In the hospital, I have had a problem with that because on the ambulance, they're like, well, what's your option? It's like it's me and you. So, actually, once I delivered a baby and I had a female partner, but the female partner ended up driving us to Fort Worth. So it just kind of depends. Just read the room. Now, teen pregnancy, I put the teen mom thing on here because we're seeing so much of this, and in fact, it's almost glamorized in American culture. And I'm not saying being a teen mom is is a bad thing or it makes you a bad person at all. What I'm saying is it certainly does increase the risk of poverty and low birth weights and disparities in education and a lot of issues for social issues. It doesn't make them less of a human or not a good person, but I'm just saying there are social issues and health issues associated with teenage pregnancy in the United States, but it's very common in the United States. So this is from unprotected sex, of course, but also I think we're seeing patients have sex at younger and younger ages. And so, anyways, all this to be said, pregnant teenagers may not know they are pregnant or they may be in denial that they're pregnant. So you should respect the teenager's privacy and assess and obtain her history away from her parents. And so, this might be a good one where you ask them, like, when they're in the back of the ambulance, okay, for real, when was the first day of your last menstrual cycle? Well, I haven't had it in 8 months. I've gained 40 pounds or 30 pounds or something like that. It's like, okay, do you think there's a chance you're pregnant? Well, yeah, I have sex with my boyfriend without a condom. Well, yeah, you're probably pregnant, So that happens. Used to work at a pediatric hospital. We get this like all the time. 15-year-old would come in with abdominal pain. Well, before we do a CT or scan or anything like that, we do a pregnancy test. And so they'd be pregnant, and this pediatric hospital does not take care of pregnant patients because you're an adult at that point. And so they would ship them out. We would literally bool them across the street to Harris downtown. So, anyways, that happens. So childbirth is seldom an unexpected event. Usually you know it's coming, but there is an occasion when it becomes an emergency. We'll talk about what they are. And so take good standard precautions. This is the one where you are going to want to take the time to put on a gown, boot covers, gloves, and like really gown up because this can get messy, okay? So wear a gown if you have time, always. Consider calling for additional resources. This can be done with one or two people, but the mechanism of injury, do your scene size up. I don't have anything to add to that. Form your general impression. So this is really actually an important thing to do is you got to determine, are we going to stay in play or let them go? Is delivery imminent? Are they in active labor like they're about to deliver to where I can't get to the hospital in time and get them to an OB room and an OB doctor and OB assessment in time? Or, oh, wow, they're going to deliver in the next 10 to 20 minutes and I'm 10 to 20 minutes from the hospital. Well, then you need to deliver on scene. Okay. And so you do your rapid exam, when trauma or other medical problems are present, evaluate those first, of course, like low blood sugar or hemorrhage or something like that. But, always, again, if mom dies, the baby will die. So assess the woman's airway and breathing are usually not an issue at birth, but, just watch, assess their airway. I don't have a lot to add on some of these. External, internal bleeding or potential life threats and should be assessed early. So blood loss after delivery is expected, but it definitely shouldn't be more than like 500 milliliters of blood ever. And so, but significant bleeding is not normal. So when you start having passage of large clots and stuff like that, that is not normal. And so that is life-threatening bleeding. So we call that postpartum hemorrhage, and this is the number one cause of this is the cause of death of parents of mothers in pregnancy. Is after the fact they bleed and bleed and bleed and they die. And so be very cognizant of this. This does kill mothers all the time. The most common way you will die related to a pregnancy is postpartum hemorrhage. And so if signs and shock are pregnant, control the bleeding, give oxygen, and keep the patient warm, just like we do any patient. And so if delivery is imminent, you really, like I said, you have to deliver on scene. You do not want to do this in the back of an ambulance. You can't really do this in the back of a moving ambulance. So the ideal place to deliver is in the woman's home if you can do it. If delivery is not imminent, prepare the patient for transport. Okay, and so for the patients that you're not going to want to stay on scene is the patients that have a significant amount of bleeding and pain. Okay, they really need a hospital and a doctor. That's not normal. Are hypertensive, you have to worry about that leading to, which would be preeclampsia, into eclampsia is when they start actually having a seizure or have an altered mental status. Those are all medical emergencies that really need to be handled in the hospital. And so you're going to obtain what we call a thorough obstetric history. So they should know this based off of calculations you can do off their menstrual cycle and the conception date. So you'd say, what's your expected due date? Okay. Is there any complications you're aware of? Like gestational diabetes or hypertension or anemia or group B strep or something like that. If she's been receiving prenatal care is very, very important. If they tell you no, you need to be prepared for a shit show. Like it's not going to be good. Like it's not going to be good. If you are delivering a baby that does not have prenatal care, like buckle up. It's going to be tough. Something's going to go wrong, especially in the pre-hospital environment. So be prepared. And a complete medical history, right? Oh, okay. Well, your pregnancy's been normal, but you have epilepsy. Okay. Oh, your pregnancy's been normal, but you have iron deficiency anemia or whatever. Just be aware. So we do the sample history. So the due date, frequency of contractions. So as contractions get closer and closer, the more likely they are to deliver. Okay. And so when contractions are within like a minute of each other, delivery is going to become pretty imminent. And so, contraction is when the uterus is squeezing. So the uterus will squeeze and then it relaxes. And when it squeezes, we call that a contraction. When it relaxes, it's no longer contracting. But when they come back to back to back to back and they're really on top of each other, these contractions are becoming more and more frequent, intense, and less latent, meaning they're just happening closer and closer in time to each other. Delivery is becoming imminent. Okay. And so you're probably going to end up they're going to deliver. Okay. And so, also be aware if the water has broken, you should ask what color is the fluid. If it's green, that's called meconium staining. This word right here is called meconium. And so what meconium is this is the baby's poop. So this is baby poop in the amniotic fluid. And so what this means is it's from an increased amount of stress on the baby. And so if the baby's been in the birth canal for a long period of time, or it's been a stressful delivery, or something like that, the baby will like poop in the amniotic fluid. And so the problem is when baby breathes in. So normally babies are breathing and swallowing in their amniotic fluid, their urine. Well, urine sterile. But when a baby like breathes in poop, it can cause problems. And this poop's called meconium, and it's a green color. It causes problems with the baby's lungs. As you can imagine, baby poop and lungs just can't be good. So you see this in stressful pregnancy or stressful deliveries, prolonged deliveries. It's not good. It's not like it's going to kill them immediately, but it's certainly not good. It means the baby's been under stress. And so, you do a physical exam. You would assess for fetal movement. So the baby should be moving. And the mom, if they tell you like, no, my baby hasn't moved in 2 hours, baby might be dead. Now, I can tell you, especially if like you can't stimulate the baby to move. Mom can't mom will say I can't get them to move. Normally if I do this, they'll move. That's not a good thing. And so one way that we do this, and the OB doctor showed me this in my rotation, is you can just take your phone, have someone call you and have it vibrate and just set it on the lady's belly. That's called vibroacoustic stimulation. And so typically that should get a baby to move, is vibration and sound. Okay? So you could just have someone call you and set your phone on, or their phone on the baby, or on the pregnant lady's belly. Okay, so if you suspect the delivery is imminent, we're going to check for crowning. I'm going to show you what crowning is. That's when the crown of the head is coming out the vagina. Delivery is very imminent. Like if you see that, they're going to deliver in the next minute or two. Obtain a full set of vital signs, hypertension, even mild, could lead to eclampsia. What is eclampsia? That's seizures in pregnancy with hypertension. It's very bad. Okay. And so, if delivery is imminent, you're going to notify the receiving hospital. I will have you know, you won't be tested on this. You almost always don't go to the emergency room with pregnant patients. You actually bypass the emergency room and will go to the OB section of the hospital. And so that's a huge pain because usually there's not an ambulance bay at the OB section. And so you got to walk like a long distance to make your way to the OB area and deliver the baby. And the OB nurses are all irritated. You brought them a patient. And so, yeah, it's a mess when this happens. I don't like doing that, but you'll usually, like when you call the ER, they'll say, okay, cool, please hold. And they're going to transfer you to the OB floor. And you're going to have to talk to the OB nurse. Okay? Now, if you're trying to deliver a baby and it doesn't happen within 30 minutes of trying, you should just start transporting. That means something, like say they're crowning and you see the tip of the baby's head sticking out the vagina and it's been stuck there for 30 minutes, like that's really bad because that's too long. And so you should just start transporting. They may have to have surgery to remove the baby surgically. For a pregnant patient with with a complaint unrelated to childbirth, be sure to include the pregnancy status in your radio report. So, you can have a pregnant lady with, I don't know, a cough, something like that. It's not necessarily related to pregnancy. And so we still need to document, okay, the lady's 28 weeks gestation with adequate prenatal care, the baby's at, a normal height and weight as predicted by sonography or whatever. You just still put that in your report. Now, this is important and annoying, but it does happen. If you deliver in the field, that is now 2 patients, which means it's 2 charts. And so you actually really do have to write a chart on mom and the baby. And that's not like funny, like for real. You really do have to write 2 charts. Okay, that's 2 patients. That's 2 human beings at that point. Lots of paperwork. All right. So I don't know why, but EMT schools are obsessed with the stages of labor. And there's 3 of them. There's more, but there's 3 you need to know. So we got to know these 3 stinky stages of labor. So and we're going to talk about what each of these are in more detail. But the first stage of labor is dilation of the cervix. So remember, if you were to look into, which we don't do this, but if you look into a vagina, right, the cervix is the neck of the uterus. And so normally it's a whole, like, it's like this. And so it's normally pretty tight. Like you shouldn't be able to get a lot through that. And so what happens is as the baby starts pushing down, their head, hopefully, is pushing down on the cervix, it will dilate. What is dilation? Meaning it opens up. And so instead of this tight hole that it once was, it is now opening up. That's called dilation of the cervix. And so if you've ever heard like a pregnant lady be like, hey, I'm 2-3 centimeters dilated, they're saying that's how far their cervix is dilated, okay? And so doctors and nurses, not paramedics or EMTs, will stick their fingers in the vagina. We do not do that. And they will measure the dilation of the cervix, okay? And so, someone that's dilated less than like 7 centimeters, okay, they're not going to deliver anytime soon. But if someone gets up to like 8, 9, 10 centimeters of dilation, they're about to deliver, okay? And so the first stage of labor begins with the dilation of cervix, okay? And the next, and so this is the longest part of labor, by the way. So this could take a day, especially if it's a new mom, for her cervix to dilate big enough to push the baby through. And so the cervix not only dilates, right, but it effaces. So like, look at my hand. See how like there's like area around this divot that would be the cervix? As I open it up, that space will become thinner and thinner, okay, and that's called effacement. And so the second stage is expulsion, so we call this is when there's descent of the head and pushing phase. So basically, this is when the head starts pushing past the cervix, and so basically the cervix has been fully dilated, okay? And so you can see this here. Let me just zoom in. Again, first phase, the cervix is starting to dilate, okay? And what's happening in the second phase is now the head is pushed past the cervix, okay? So it's coming out of the cervix into the vagina. And then so that starts when the head enters into the vagina past the cervix, and the second phase ends when the baby's fully delivered, okay? And I'm not being pedantic on this. They will ask you, Oh, the baby's head just pushed past the cervix. What phase of delivery is this? Phase 2. Oh, the baby's been fully delivered. What phase of delivery just started? It's phase 3. So they really do test this, okay? And so phase 3 is when you deliver the placenta, also known as the afterbirth. And so the placenta will detach from the uterus, and eventually it'll come out of the cervix and the vagina and be expelled. That should happen like 5 to 20 minutes after delivery, 5 to 30 maybe, after delivery normally. Okay, and so there will be blood and stuff coming out when this happens as well, but this should expel pretty quickly. When the placenta is delivered, you want to take that to the hospital. You put it in a bag or like in a bucket and take that to the hospital. They look at that in a laboratory to make sure that it's all there. Okay. So again, first stage is when the beginning of contractions. It's usually the longest stage. And so it ends when the cervix is fully dilated, okay, which is 10 centimeters. And so just be aware that this is on average 16 hours, okay? It's a very long stage. It's like a day. And so the uterine contractions will become more and more regular and last about 30 to 60 seconds each, okay? And so the frequency will increase, meaning they will be closer to each other in time, and also they will become more powerful. And so this is what I was talking about, the effacement thing. Look, this is a normal cervix, but see how the cervix was thick here, but now it's becoming thinner? That's called effacement, okay? And obviously dilation is when it's opening up, okay? And so labor is generally longer in primi-gravida women. So this means that it's their first pregnancy. Instead of a multigravida lady, this means that they've had multiple pregnancies, okay? And so if you don't know this whole gravida pravida thing, it's basically say like G is how many pregnancies you've had, and then P is how many live births you've had. And so I call my grandpa G-Paw, and so I know the G becomes before the P. So that may help you. So you might see someone who's like a G1, P1. That means they were pregnant once and they delivered once. But maybe now they're a G2, P1. What does that mean? They've been pregnant twice and they've delivered once. Okay, and so we use this if someone's like a G5, P0. What does that mean? That means they don't deliver babies very well. Like they keep miscarrying, and so we use that clinically. So you'll see this acronym sometimes, the GP, and you'll chart it as well. Now, the woman may experience preterm or false labor, or what's called Braxton Hicks contractions. So this itty bitty table talks about this. So let's divide this in two. So Braxton Hicks are also known as false labor contractions. And so Braxton Hicks are contractions, but they're not regular and they don't increase in intensity or in frequency, okay? So these will be contractions that kind of come and go. So they'll be like, this isn't true labor, okay? Because remember, true labor, it will get stronger and more frequent and tighter, and so and more painful. And so that's true labor. But a Braxton Hicks is just like a contraction or two that are irregular, okay? And so just be aware of that. And then, and also like the pain of a Braxton Hicks is like, we'll stay in the lower abdomen, but the pain of a true labor will wrap around the lower abdomen. Physical activity or position may alleviate the pain with a Braxton Hicks contraction. With a real one, it won't change anything. If the bloody show, if present, is brownish, right, and Braxton Hicks, the bloody show is the discharge of like the mucus plug, and it can have some blood with it, and so it's generally accompanied with mucus when it's truly a bloody show. That's what they call it in the literature. Obviously, it's in your book, and so. Just be aware, Braxton Hicks. So if they describe someone 36 weeks pregnant, they've had 2 contractions in the last hour that felt irregular in the lower abdomen, they're probably trying to tell you that's Braxton Hicks contractions. When they tell you someone has had like the bloody show and they've had amniotic fluid rupture and their contractions are becoming more and more frequent, then they're really trying to push you to think, oh, well, that's probably true labor. Like that's probably a true contraction. So again, some women experience a premature rupture of the amniotic sac. So this sac, if it ruptures early, like in the 33rd, 34th week, creates all these problems for the mom. They have to go in the hospital and stay in the hospital usually, or do we just deliver the baby? And so if that happens, just take them to the hospital. The head of the fetus descends into the woman's pelvis. As this is the head should come first, right? And so this descent is called lightening, okay? And so, yes, I have actual pictures of delivery because you will do this, okay? And so we have a birthing simulator at the training center that we'll talk about, but this is a full-blown head coming out of the vagina, obviously. And so this is this is obviously what we would call crowning. The crown of the head is now sticking out of the vagina. Okay, the whole head's not out. So if you walk up and you see this, do you think you should stay on scene and deliver this baby or drive 10 minutes to the hospital? You can stay on scene and deliver the baby. The baby's coming out, whether you like it or not. Okay? And so the second stage is when the fetus begins to enter the birth canal. So remember, when parts of the fetus are past the cervix now, you're in the second stage of labor. And so the uterine contractions will get closer together and more powerful and will last longer. And the perineum, which is the skin around the vagina and the anus, will bulge. And so when that starts bulging, you know, okay, well, there's a head about to come out of the vagina. And so you might even see hair too. So you might see hair at the vaginal opening. Okay, it's still crowning. Okay, and so that would be delivering a baby. The second stage is from the point that parts are in the birth canal to the part, and it ends when everything's out. All the baby is out. The last phase, the third stage, the final stage of labor is when you start delivering the placenta, and the placenta should be fully delivered for it to end. That's what the placenta looks like. It's very bloody, very slimy, so be careful. Again, you should put this in a bucket or a bag and take it to the hospital. Do not throw it away. And it can take up to 30 minutes to deliver. Now, when considering to deliver at the scene and when to go, again, if delivery is imminent, you just need to deliver on scene. Suck it up, right? You're in the field of EMS, so just be aware. Now, also with a natural disaster, inclement weather, environmental factors, traffic, you know, all these things that you're not going to get to the hospital in time, then you need to deliver. Also, you cannot deliver a baby in a helicopter in most helicopters. So we don't typically fly patients in labor either. They can't. The feet are facing towards the pilot, and so it's very hard to deliver a baby in a helicopter. A lot of them won't even accept it. Like the helicopters will deny the flight. And so to determine if delivery is imminent, and there's really no reason to deliver or to fly a pregnant patient. And so to determine if delivery is imminent, ask the patient, how long have you been pregnant? When are you due? Is this your first baby? Are you having contractions, right? These are all things that we've asked. How far apart are the contractions? How long do they last? You know, and something you'll know is the mother will say like, oh, the baby's coming. The baby's like, they know, they can feel it, right? The baby is about to come out. Especially if they've had a baby, they'll tell you like, no, I'm going to deliver like right now. Like I'm about to deliver. So to determine if the delivery is imminent, you'll ask the patient, have you had any spotting or bleeding? Has your water broken? Have you felt as though you need to have a bowel movement? A lot of times they'll feel from that pressure of the uterus and needing to push. It's called tenesmus. They will feel like they need to poop. And sometimes they do poop. Yeah. And so you just clean it up. You know, it's part of it. And so, and ask them, do you feel the need to push? If they're like, yes, my water broke 30 minutes ago. This is my fourth child. I feel like I need to push. Then you don't try to transport. You deliver the baby. And so potential complications, if you want to determine the potential complications, you need to ask, were your other or previous deliveries by cesarean section? That means that the mom was not capable of having it vaginally, obviously, so they had to cut it out surgically. If they do say yes to that, that's a red flag. That tells you this might be a complicated vaginal delivery. Typically, if you have a cesarean section, you don't have vaginal deliveries after that. Typically. So that's like a known thing, right? So if they say like, oh, I've had 2 children and both of them were cesareans, this one's probably not coming out of the vagina. They need to go to the hospital and have a C-section. Have you had problems in this? Have you had problems in this or any other previous pregnancies? Oh yeah, my 2 other pregnancies I delivered at 32 weeks. Oh wow, that's bad. You know, do you use drugs, drink alcohol, or take any medications? Is there a chance of multiple deliveries? You know, so is this twins or triplets? Does your physician expect complications? Those things, you know. If the patient says that she is about to deliver, she has to move her bowels or feels the need to push, you should prepare for delivery, okay? And so, again, watch for that in the vignette. If they say, I feel like I'm about to deliver, or she tells you she needs to move her bowels, or it can be any of these, or they feel like they need to push, The answer is stay on scene and deliver the baby. Okay. So you would visually inspect the vagina for crowning. Again, that could just be a little bit of hair sticking out of the vagina. We don't touch the vaginal area unless delivery is imminent, right? Which is mostly done through visual inspection, not palpation. And so once labor has begun, it cannot be slowed or stopped. So ready or not, here the baby comes. And so you need to just be ready for that. And so, like I said, if they tell you, oh, I feel the need to push, I feel like I need to poop, I feel like this, I feel like that, it's too late. The baby's coming. Get ready. Do not let her go to the bathroom. A lot of times they'll feel like, oh, I need to poop, I need to poop. Just have them poop in the birthing position, which we'll show you this in class, with like the frog leg position. Just have them poop right then and there, wipe it out of the way, and keep going. Okay, that's fairly common for them to poop in delivery. Remember, if you deliver at the scene, you are only assisting the woman with the delivery. Really, like I said, this has been happening since the beginning of time without EMTs and paramedics, I promise. And so this is an OB kit. And so inside the OB kit, there will be like a bulb suction, and there will be 2 clamps to clamp the umbilical cord. If this is the umbilical cord, what you do is you put a clamp here and a clamp here, and then someone will cut here. And so when you cut through there, that's cutting the umbilical cord, but you clamp it on both sides first. There will be like towels. There will be a scalpel to cut this, or a pair of scissors. Usually it's a scalpel. What else? There's all sorts of stuff in there. There's usually like a beanie and like a blanket to keep the baby warm. We'll open one up in class and show you what's in it. Now, also, these kits are sterile, but birthing is not a sterile process at all. So patient position, preserve the patient's privacy as possible. So again, if they do go into labor in the Walmart, you might want to move to the ambulance for that. It's going to be a mess, but don't let them deliver in the bread aisle of the Walmart. Place the patient on a firm padded surface with blankets, sheets, and towels. You better get a tarp because it's going to be bloody and lots of fluid and a mess. So we used to actually have tarps on the ambulance, like a medical grade tarp. And so, yeah, I would be putting that down if I were going to deliver in an ambulance. I've never delivered in an ambulance. Elevate the hips about 2 to 4 inches. Okay. This helps like with the positioning for the baby to come out. And so the baby's shoulders not dragging the ground when it comes out. Have her knees and hips flex and her feet flat and her knees spread apart. We'll show you this position in class. And so to prepare for the field delivery, again, we're going to do this on birthing simulators. Each of you will do this in class individually. We'll help you. You're going to place towels or sheet on the floor around the delivery area. Open the OB kit carefully. Put on your sterile gloves. Again, this isn't a sterile procedure, though. Use the sterile sheets and drapes for the OB kit to make it sterile delivery field. I don't know why I keep saying this is not sterile. And you really are just trying to minimize. You should try to do it clean, but this is not sterile. And so this is what they're talking about, like draping and stuff. So you'd want something up underneath the butt and over here on the legs, right, to just kind of, prepare the site. And you deliver. So yeah, your partner should be at the patient's head to comfort, soothe, and reassure, and assess and to allow oxygen if needed. Continually check for crowning. Some patients experience what's called precipitous labor in birth, meaning it happens very quickly. Who gets that? Multi-gravid women, right? The women that have had a lot of pregnancies and deliveries. And so position yourself so that you can see the perineal area at all times. Perineal area at all times. Excuse me. And so you're going to time the patient's contractions. So you'd want a watch. You should be wearing a watch on an ambulance. And so remind the patient to take quick short breaths during each contraction, but not to strain. So sometimes you almost have them pant like, right, to where they're really kind of like, you have to make sure they breathe because they'll push down and bear down so hard trying to strain to push out this baby, they can have syncope and pass out. You don't want that. And so between contractions, encourage the patient to rest and breathe deeply through her mouth. Okay. So between the contractions that last 30 to 60 seconds apiece, you might have like a 5, 10, 15-second break to where you'd ask the patient to pant and like to breathe through their mouth to try to facilitate their breathing. Okay. Deliver the head. Hopefully the baby comes head first. If it doesn't, that's the next video. We're going to talk about, well, what happens if the foot comes first or the butt or the leg or the arm or something like that. It's a mess. So support the head with your gloved hand as it rotates. So you want to support this baby's head, and it's weird. Sometimes it'll come out like nose up, and it should rotate and look towards the mom's thigh as the shoulders come out of the vaginal canal, because the vagina, is shaped like this. And so you want the baby looking this way towards mom's thigh. His eyes are looking this way because the shoulders are going to come through these widest areas like that. So that's what you want to happen. And so you can apply a gentle pressure across the perineum with a sterile pad to prevent this from tearing. And so, like, I wish I had like a birthing simulator, but like, what you would do is you would kind of like pad with a pad this area because it's going to be bulging out so hard. You kind of want to like pad and gently apply pressure to that to try to like push it to keep it from tearing. You're trying to keep it from tearing because if it tears, it's going to cause bleeding, and pain. But just be aware of that. Patient might have a bowel movement, so you might have a code brown. And so be aware you are in the splash zone. This is another reason you wear goggles and gowns and a mask when delivering a baby. You are in the splash zone of amniotic fluid and poo-poo fluid. And so be aware of that. Be careful to not poke your fingers in the newborn's eyes or the fontanelles. What's the fontanelles? That's a soft spot on the top of a baby's head. There's 2 of them. And so if there's an unruptured amniotic sac, you might have to take your finger. So basically, like the mom's pushing, and instead of seeing a head, you see a sac of fluid. At that point, it is allowed to stick your fingers on that sac and kind of twist it and tear it between your fingers, or you could use a clamp. But really, I would try to use my fingers first because you don't want to stick a clamp or something in a baby's skull. And so sometimes you might have to pop the water for them, okay? The reason this is it'll suffocate the baby, and they're probably not going to pass through the birth canal if you don't do that. So you have to do it. Now, when the baby comes out, this is very important. It is the baby's mouth, then nose immediately. So as soon as it's out, the baby's going to go, oh, wow, they're going to start crying, right? And so you want to suction out the baby's mouth first, and then each nostril. The mouth is first. Now, this is bad. It's called a nuchal cord. Spelled like this. Nuchal cord. Meaning like a noose, like how you hang people, a nuchal cord. And so the umbilical cord is wrapped around the neck. And as soon as the head is delivered, you're going to use one finger to feel whether the umbilical cord is wrapped around the neck. So you could stick a finger around the neck and feel. If you feel an umbilical cord, what you need to do is slip that cord up over the baby's head and unwrap that from the baby's neck. It is choking them. And so if you can't do that, say it's too stuck, what you have to do is you have to cut it with a scalpel. So very carefully you would cut it because this is going to kill the baby. Okay, it's choking them. Once the cord is cut, now the baby has lost its lifeline from the placenta, so you need to deliver the baby like right then. Okay, now this is a very odd picture to me because that baby's like, dude, can you help me here and not take the picture? This is bad. So sometimes this cord's wrapped once around the neck. Sometimes it can be wrapped like 2, 3, 4 times around the neck. And so if that's the case, and you can't slide it off of the neck, what you do is it's the baby, you try to like slide it over the head and try to get it off the neck and untwist it. But if you can't do that, you have to cut it, or else the baby will die. And again, this is called a nuchal cord. It's one of the few times you can stick your finger in the vagina to try to facilitate getting this off. So once the head is born, the body usually delivers easily. Generally, the shoulders are obviously, sometimes those can get stuck. That's called shoulder dystocia. But yeah, the shoulders can get stuck. Supporting the head and the upper body, but true, once the head's out, the baby's coming. They've made it through the hardest part at that point. Support the head and upper body as the shoulders deliver. Again, babies are slippery. And so the newborn will be covered in what we call vernix caseosa. That's this word. This is that wax type stuff that's on a baby. And so when they're covered in vernix, they're slippery. So be aware of that. Don't be dropping the baby. You'll never live that down. And don't pull the baby from the birth canal. So if these babies get stuck, you may think like, oh, I'm just going to yank on its head and pull it out. You're going to decapitate the baby or cause, seriously, you're going to cause a problem for the baby. So don't pull on babies ever. We don't ever pull or yank. Don't do that. And that's it for this video. On the next one, we'll talk about like what happens if the butt comes first and not the head. What happens when the baby's born? How do we determine if they're healthy or not? We use a scoring called the APGAR score. So that's what the next video is, and then of course there'll be some questions at the end. So I appreciate y'all's time.